Okay, so maybe I'll get started, and then we'll let the others join in. So my name is Dr. Paul Chang. I'm a reproductive endocrinologist at TRIO Fertility, and this, I believe, my 15th or 16th year in this field. So I'm really excited. I see some familiar names actually in the attendees, so welcome. So I'm excited for you to join. And because currently there are actually no questions, I'm just gonna kind of freely talk about a few things, and maybe that'll generate some questions. So I guess the thing about why I like what I do is fertility is really a wonderful field. I get to meet such interesting people that inspires me and make me want to wake up and do what I do every day. It's through the conversations by listening to you, patients that I really get a good understanding of what's important to you, and I always focus my care on, individualizing what you are sharing with me. And I put that together in kind of a like algorithm, looking at what your wishes are, what are your worries, what are your concerns, but also what does the facts say, like what does the test show us, and then it's by putting all those pieces together. I try my best to give everyone a individualized care plan that focuses on those attributes and those wishes and wants. So I have a question, and thank you. This is regarding, so I'll read it. I have had three unsuccessful rounds of IVF, and I'm really sorry about that. And you are currently 39 years old. The question is, trying to improve egg quality before the next cycle, and I think that is amazing and great way to focus. And the question is reading about royal jelly. What are my thoughts on if this could help? Truth be told, and I tell this to all my patients, I'm a reproductive endocrinologist from Western medicine side. So I personally haven't come across any good studies that tells me whether or not royal jelly is good for eggs or not. That said, I don't think it's dangerous at all. I certainly think royal jelly is a good, health supplement, and maybe someone who's maybe more knowledgeable, who might be able to answer your question, maybe a traditional Chinese practitioner, naturopathy. I think those people may give you more insightful response as to the role of royal jelly. That said, I can't imagine it be harmful, and I really like your focus, which is doing things to improve your egg quality before trying to attempt another round of IVF. Now, of course, there are many factors. Obviously, it would be impossible for you to provide on this, public forum the details. But ultimately, I do think really my approach to someone who's done 3 rounds of IVF would be to really, sit down with your doctor, focus on what went well, what are areas of improvement. It could be medication, so it could be the medication, the protocol used, pre-preparation, such as like you are thinking royal jelly, naturopathy, traditional Chinese medicine, even diet, exercise, de-stress. And then ultimately, other little details in terms of the actual IVF protocol, and then as well technologies that may help assist you to have better outcome. So don't give up yet. I think there's more to be seen, and so please make sure you follow with your doctor and have a detailed, thorough review to make sure all stones are unturned. I hope that kind of helps you. All right, next. Does the success, so thank you. So we have a question from the attendees asking, does the success of a blastocyst depend on the age of a woman's egg? And what is the general success rate of a blastocyst generated by a 40-year-old woman? So great question there. So let's go back to a little bit of biology 101. So all the eggs in the body, so talking about eggs, are given to you the moment you are formed in your mother's womb. So that means in this case, you are a 40-year-old woman. So these eggs are now 40 years old. So as one ages, you start to use your eggs. Every month you ovulate. So there's less and less eggs left in your body, but also whatever is left is a bit older. So knowing that, when that egg then meets a sperm and becomes a blastocyst, then generally speaking, that blastocyst will be of lower quality. So in terms of the blastocyst, we can look at them, so we can look at how nice they look. Modern science currently also affords us the ability to genetically test the embryo. And I kind of give this analogy to patients, maybe not the best, but I think people can really relate to. So it's kind of looking at an apple. It's round, it's red, it's beautiful, but how do you know how it tastes? You actually have to take a bite into it. So exactly like an embryo. So a blastocyst from a 40-year-old egg may look great, but as the sperm and egg interact to become the new person, as the new embryo, mistakes can be made genetically. And as a result, that although the embryo may look perfect in appearance, but genetically it may not be normal. So ultimately, that begets why the success rate is lower with age, even though it's a blastocyst. So what is the general success rate of a blastocyst? So generally speaking, I hope your doctor shows you this kind of age and fertility. So even though there's a blastocyst, at age 40, the success rate is, unfortunately, roughly speaking, we're talking about, I would say, 20%. Hopefully that answers your question. And we'll move on to the next question. So I have a patient who's asking me, so as part of their fertility protocol, at TRIO, we often put patients on birth control pill as a way to synchronize their follicles. So part of the IVF process is to give my patients medications to let many follicles grow. But when you do that, it's kind of like, here's another analogy, kind of like like you have a race. You can have all the racers randomly start racing and running wherever they want on the track. It's going to be really hard for me to find out who's winning. So versus if I line them all up and I go bang, I can then track, the progress of the race better. So same thing here. We're using the birth control pill to synchronize the follicle. So when we're ready to start the injections, then they will have a better chance of having many grow at this kind of the same rate, rather than having some growing faster and then some just don't grow. Now, in terms of how many days that we put patients on, now that's generally speaking, we put patients on roughly 2 weeks of birth control pill to synchronize. However, we do encounter special cases where we try that and the patient's response, which is, by the way, rare. What I'm about to share with you is rare, but we do adjust the number of days if previous attempts show that, birth control pill, they have bad reactions to it, for instance. And so therefore, some people just feel uncomfortable on it. And therefore, we will reduce the timeline and the duration of birth control pill. And sometimes we might even just remove it because, the side effect is, too great for that individual. So it's always going to be individualized. But on average, it is about 2 weeks. I hope that answers your question. Great. Okay. I have a question, and this it states: would you recommend genetic testing on embryos? And PGTA or PGD, is one better than the other? So first of all, let's differentiate the difference between PGTA and PGD. PGTA is pre-implantation genetic testing looking for aneuploidy. Aneuploidy are chromosomal problems, and those are the number one known cause of why, kind of referring back to, I think, the earlier questions about age and blastocysts. Well, those blastocysts are less likely to be successful because they're likely to have chromosomal errors, and those errors are likely exactly that can be detected by PGTA. So that's kind of where the link is. PGD is called pre-implantation genetic diagnosis. So that is specifically pertaining to, so someone knows that there's a disease that runs in their family. So now you find the probe, you create the kind of the lock and key scenario, and then now you go in and look for that specific disease. So it's one particular disease. So pre-implantation diagnosis is diagnosing, trying to find that disease amongst the embryos so we can pick them out. Versus a PGTA is a screening of the 23 pairs of chromosomes. So I hope that gives you a sense of what the differences are. So they are both kind of looking at the genetics, but one is a screening tool and one is looking for a particular disease. So it's not which one is better than the other. It's just, it's used for different reasons. So if you don't have a family of diseases that run in your family, then there's actually no role for PGD. So would I recommend genetic testing on embryos? I would say it really depends on, it's a very nuanced conversation. And again, it depends on the patient's wishes and wants. Very generally speaking, again, alluding to the first question, because the impact of age on embryos leading them to fail is because of chromosomal problems, there is definitely greater benefit of people considering PGTA when they are of older age, especially after 35 or 37 years old. That said, for people who have had many miscarriages before, even though they're younger, and they just want to optimize their chances, they have one shot at IVF, or they don't really envision themselves doing multiple rounds of IVF. They also want to minimize a miscarriage because they have had one before. Then that decision to do PGTA may be an important one, because that person may wish to find the best embryo to use so that their journey to, a live birth successfully will be, the most direct path. Hope that answers your question. And the next one. The question is, how do I prepare for frozen embryo transfer cycle? So I am not exactly sure what, because there's different ways to think about that question. Are you thinking about how do you personally mentally prepare for it? Or is it more like medically, how do I, the doctor, kind of prepare patients? So maybe I'll try to answer both. So how does one just prepare for frozen embryo transfer in general? I think that's the same approach I would recommend for all my patients. Once you have a plan with your doctor, try your best to, ask a lot of good questions. But once you made that decision, I really encourage you to come to feel at peace of that decision and feel that, you've done all the work, but because the decision's made, that's not really the time to start to kind of, do more research, because at some point we have to, transition from planning to doing. And when you're doing, I feel like the important thing is, our body, of course, I'm speaking very generally kind of a generic way, but speaking about myself, I just don't think my body can tolerate everything. I can't multitask all the time. I can't be working out and trying to talk to patients, because there's just so much going on in our body. There's only so much blood supply that can, be shared by all the cells. Is it going to go to the muscles? Is it going to our brain? Is it going to go to our reproductive system? There's always this kind of, your body's trying to balance where everything needs to go. So therefore, I truly believe once a decision's made, the best is to be comfortable with that decision and really focus on, meditation or whatever it takes to kind of feel, positive, hopeful. So that's kind of my answer as to, leading up to the embryo transfer. And by the way, that applies to other things as well, like IVF or fertility, IUI, just everything in general, life in general even. Now, in terms of the actual preparation for frozen embryo transfer, there's actually two approaches. So you can actually do a very natural approach using one's own menstrual cycle to kind of run and prepare the body for the embryo transfer. Now, that said, that type of protocol is best for someone who is younger with really regular menstrual cycles, because again, I'm relying on the body to do everything. So I have to trust that the body is still at its peak and is able to do all the things, such as growing a follicle, making enough hormones to prepare the lining, leading up to then us placing the embryo into the body. The other method allows me, the doctor, to be more in control. So I don't rely on the body's own ability. I actually can provide and replace estrogen and progesterone in the form of tablets. So by introducing estrogen into the body, I can build up the endometrial lining. Once the lining is thick enough, I can introduce a progesterone, which then starts the countdown to the embryo transfer. So there's two approaches, a natural and a medicated one. And but of course, the ultimate decision will be between you and your doctor to really sort out which one might ultimately be best. And sometimes they're both equally. By the way, they're both equally good in good prognosis patients. So ultimately, it may be just sometimes we use one and then the other based on patient preference. So hopefully that helps. Plus, next question is, can Chinese medicine herbs really help with egg quality? Few questions ago, I kind of, so I'm going to kind of answer that similarly. I am, Western trained doctor, although I am Chinese. I don't know anything much about traditional Chinese medicine, but I do want to share with my patients that in my 16 years of doing this, I absolutely have seen patients in whom why don't I just share this story with you? This must be now 4 or 5 years ago. I had a patient who came back to see me to do the second round of IVF. So because prior to that, she maybe 3 years prior, she did an IVF cycle. Whereby, but by the way, this woman is, she's, I think, 34 when she first did her first round of IVF. And although she made many eggs, she, I think, only ended up with 2 embryos and only one that was usable. But good news is she's pregnant, and that's why she's coming back to see me. And what was interesting is that in the second round, although I didn't change, I made some small adjustments. Maybe they're that awesome, and so everything's better. But I doubt it. I still, I was a little bit surprised how well she did in the second round of IVF. She actually made many eggs, but this time made many embryos. So I asked her, what is the secret here? And she shared with me, she continued to work with a traditional Chinese medicine doctor. So after that first session, she started to work with traditional Chinese medicine doctor. And then, so 3 years later, she's back to see me. And I witnessed it. She did better. So other than to share with you that I've seen it in action, but of course, I can't really explain to you, more deeper than that. All I could ask is if you're interested, please speak to a traditional Chinese medicine practitioner to learn about their insights, or talk to a family friends who've used one with success. I'm really open-minded, but unfortunately, I don't have a good answer as to can Chinese medicine herbs help with egg quality. Next question. In what situation do you recommend doing a fresh embryo transfer? Also, what situation would be beneficial to transfer 2 embryos in a fresh cycle? Thank you for that question. And so you're speaking to a doctor that, generally speaking, when I do IVF cycles with my patients, I highly and generally recommend only doing frozen embryo transfers. And it's because a lot of research around embryo transfers tells us that, looking at papers and stuff, that pregnancy rates trends better with frozen embryo transfers. And also a lot of research showing that babies born from frozen embryo transfer, their birth weight is similar to natural conception versus those who conceive with a fresh transfer. Now, no one truly knows why, but I have some theories, and this is my theory. We all, for those whom have gone through IVF process, knows how difficult that process can be, both emotionally but physically. And, so imagine doing that and then immediately ask the body to carry a pregnancy. I kind of tell my patients kind of like climbing Mount Everest. So you reach the top and then immediately we ask you to climb another Mount Everest. So my approach has always been, whenever possible, let's divide up the components. Let's do the first part well, let's rest, and then do the next part. Now, that said, the question is, when would I recommend doing a fresh transfer? I would consider fresh transfer in my patients in whom they haven't had success previously with frozen transfers, and now, or if when they do a second attempt, they only have such few embryos. And then I will say, well, it didn't stress the body that much because we only got, a few eggs. Let's try an embryo transfer. And the last question is, would it ever be beneficial to transfer 2 embryos in a fresh cycle? Again, I believe that it's usually not a good idea to do multiple embryo transfers. Research tells us that although you do gain a few percentage points when you do embryo transfer if you put 2 back. But for instance, like if you, in an untested embryo, if you put 1 back, statistically, maybe in a young, healthy individual, 40% chance that would implant. If you put 2, it might be 50%. So you gain maybe 10%, but what you really put your risk for is the chance that you now might have multiples. And I don't mean just 2. Each embryo can split. So if I were to introduce 2 embryos in someone's body, that person can very well end up with 4. Now, I'm not saying they guarantee will, but you can't have 4 with just putting in 1 embryo. And the problem with multiples is it's just really hard on the patient. So most patients come in feeling, well, I just wish to be pregnant. But let's hold on for a second. There are actually worst case scenarios. For instance, getting pregnant, but having 4 babies. That increases the chance that they're born prematurely. And premature pregnancies are really hard on your babies. They could develop things like cerebral palsy, which is something that they acquire because of lack of space and lack of oxygenation during birth. And lastly, it's really hard on the mom's body. So that is my best answer as to it's a very nuanced conversation. Anything is possible, but generally I am not a big fan. And also the whole fertility world, we don't love, and we are not encouraging each other to do double embryo transfers. Hope that helps. Is there an advantage? The next question is there an advantage to day 3 embryo transfer versus a day 5 embryo transfer? Let me give you a little bit of a historical context. The ability to do day 5 embryo transfer is really a feat in modern science. So when I was starting to do fertility, that's 16 years ago, in fact, it wasn't possible. All we could grow embryos to was day 3. And at that time, the pregnancy rates are lower than it is today. And I still remember conversations with patients. They're like, doctor, I have so many day 3 embryos and not getting pregnant. And they're just going through 1 at a time. And back then, because just so you know, day 3 embryos have lower success rates. So we can put in more. So we would put, 2 embryos, sometimes even 3. And they're not getting pregnant. And their wish was, doctor, I just wish there's a way I can find my best embryo. But long and behold, it's happening because we discover a way to grow embryos to day 5. So these were called blastocysts. And furthermore, alluding to the earlier questions about genetic testing, we're now even able to let people know which embryos are genetically normal. These are all the wishes and wants if you could only be in my seat and listen to the plights of patients that I have to work with years ago. But because of the modern advancements, we're now talking about the ability to use blastocysts. So blastocysts has other advantages. So first of all, they are the strongest, and because they've declared themselves to be able to grow and live to day 5. So that's one advantage. And secondly, it also allows the body to better also give the body a bit more time to heal even. So before we're putting an embryo back on day 5, talking about the rest I'm hoping patients to have. So 3 days literally after their egg collection, you're in to have your embryo transfer. With blastocysts, even if it were to be a fresh transfer, at least it's now 5 days. So to me, those are some of the advantages why day 5 embryo is better. Day 3 embryo is useful, and I would only consider it because previously the patient has done IVF and all the embryos arrested. And just to make sure that we didn't close all the doors, I certainly would open that conversation. And if all we got in the second round is one embryo and it's on day 3, I certainly would, consider embryo transfer on day 3, but certainly it wouldn't be a standard of care. Again, hopefully that helps and answered your question. Next question, what is the deciding factor to cancel a fresh embryo transfer? So we would absolutely, if the plan was to do a fresh transfer, we'll absolutely cancel if the patient's at risk of hyperstimulation. So patients who are in the process of doing IVF will know they've watched this really good video from Engage that explains one of the risk of fertility, especially IVF, is something called ovarian hyperstimulation syndrome. This condition occurs at 2 points. It either can occur early or it can occur late. Early just means as you're kind of going through the process and, shortly after your egg collection, you already know you're feeling bloated, your body's filling up with kind of fluid inside your abdomen, and you're feeling nauseated. That's early onset. Late onset means you actually feel okay. And then once you've gotten pregnant, then all those symptoms start to happen. Again, belly starts to swell up with water, feeling nauseated. So whenever a patient is at risk of fresh hyperstimulation, their fresh embryo transfer must be canceled. But sometimes I hope you guys can appreciate it's not clearly obvious who's going to develop late onset. And that's also another reason this is leading to partly addressing the earlier question. Why not do fresh transfers? It's because one of the risks is late onset hyperstimulation. And so by transitioning more to a frozen embryo transfer dominant type of environment, we're trying to make IVF as safe as possible for patients. So hopefully that helps and answers your question. Next question is regarding, my egg retrieval is next week. Is there anything I can do last minute for great success in results? My comment, if you were here earlier, you'll see that at this time, it's best to ride the wave. Enjoy, be positive, de-stress, rather than trying to focus on what can you do now. Because the point, as I said, when you made a decision to do this, that means you already did your best work. Enjoy the ride, enjoy the process rather than doing anything else. So I don't really fully have any good suggestions other than good luck to you, and I wish you have much success. So just to let everyone know, we're kind of, so maybe I'll just answer a couple more questions and then we'll maybe wrap up. But by the way, thank you so much, everyone, for attending tonight. It's been so fun answering these questions. I hope it's been helpful to you. Please give me some feedback, let the organizers know, so that way I can, in the future, when we do this, we'll try to tailor it more, to your needs. Okay, so I'm going to answer this next question. So if you are pursuing an IVF cycle and it is canceled due to only a small number of follicles being stimulated, and your doctor recommends pursuing IUI, do you have a higher success rate than pursuing IUI alone? Excellent question. It's a nuanced type of, so it may is my answer, and let me try to explain you why. So with typical IUIs, most people develop 1 or 2 follicles. If, let's say, you did IVF and you end up with 3 follicles, so maybe that's not enough to do IVF, but guess what? That's 1 more follicle than your IUI cycle. So that alone tells me there is a improvement in your chances. So that's my best answer for you. So again, it's very nuanced. So for instance, if your IUI cycle, you made 2 follicles, and in this canceled IVF cycle, also just 2 follicles, then probably not. It's probably a washout. Thank you. hope that kind of answers your question there. The next question is about hyperstimulation that I alluded to earlier. So the question is, what can you do to prevent or treat hyperstimulation? Many things. So thank you for that question. So when going again a little bit back in time, when I was doing my training, hyperstimulation probably happened 2 to 3 times a month. Today, maybe once or twice a year. And the reason is many things. So one, we have a new medication that allow us to do short protocols. So most of our patients, if they only talk to each other, will know they're actually on what is called a short antagonist protocol. Short antagonist protocol has the advantage of allowing us to use medicine and use the protocol to minimize the risk of developing hyperstimulation. So that's one answer. Two is that's why we keep an eye on how many follicles are stimulated. So there are patients whose ovaries are super saturated with follicles. So technically you can grow 40, 50 eggs, but we will never try to do that because that then puts them at risk of hyperstimulation. And then lastly, we monitor patients closely. If they develop signs of hyperstimulation, we don't put together fresh transfer protocols. And if we do decide to try fresh, we will cancel them if they look like they're at risk. And lastly, if they actually develop hyperstimulation, we do have a protocol to look after patients. So there are medications that we can offer patients to address their symptoms. But also, if the belly does get quite distended, we do bring them in to tap so we can drain the fluid to give them support, help their body recover, and help them heal up faster. So hope that helps you a little bit as to how we treat hyperstimulation, how we prevent. So I think that kind of that's enough. That's all I have time to answer for tonight. Tomorrow, I know the TRIO team will reach out, and if you want follow up and you have other questions, you can have a conversation or ask the patient care team. And lastly, if there's anything that that's medically relevant, again, feel free to ask your doctors directly. And because all of you have such great questions, I wish we can talk about this all night. But thank you so much for attending tonight, and I hope this has brought you some more insights to your care and why we doctors do what we do. Thank you so much. Have a great evening.